5 on our journey through the endocrine system, and we're going to be talking about Addison's disease just to wrap it up. In my last video, I was talking about nursing interventions, and then I just wanted to give you a follow-up. I'm not sure where the video led off, but with Addison's disease, you need to make sure the patients are taking their medications on time. Monitor their output, monitor their sodium and potassium levels, make sure they don't get dehydrated, because then the sodium and potassium will get out of whack and could certainly take their lives. And remember, this patient does not have the ability, they don't have a fight or flight response anymore. So we have to make sure that we really watch them with stress and keep them as safe as we possibly can. So the next on our journey is Cushing syndrome. And Cushing syndrome, when I think of this one, I always think of a cushion, because this patient is really fluffy. This is caused by too much cortisol, and usually from a tumor or hypersecretion of ACTH, or if a patient has taken steroids for a long time. With a Cushing syndrome patient, they're going to look kind of like this. Very round face. They usually have elevated blood glucose. Their muscles are wasting away. They have a lot of flabby fat. I don't know how else to say it. Their wounds don't heal. Their skin is in kind of bad shape, and they have what they call a moon face. So if you look at this patient, you can see their face is just way more round than even a normal heavy person's face might be. They tend to be edematous. They have hypertension. They have a lot of issues that an obese person would have, but the obesity is not caused by overeating. It's actually a disease process. So you can see that this patient might also have what they call a buffalo hump, which is like a big bump right here on the back of their neck, and then it comes on down. They have kyphosis, which means their bones aren't holding on to calcium like it should, so their bones deteriorate. And a lot of times you'll see, especially in women with Cushing syndrome, you see how her legs are pretty normal looking, slim legs, but this very rotund abdomen, face, and head. So like I said, I don't mean to be mean, but I just think of cushions and I think of a cushion. And when I was in school, that was how I remembered this. This patient has extreme body image disturbance, especially the younger they are, because they look at it as an obesity problem when it really isn't. The first test they do is a 24-hour urine for cortisol. So rethink, what do you do in a 24-hour urine? When do you start it? When do you stop it? Again, all of this heavy A&P that shines through in a lecture like this, remember, break it down to what the nursing actions are. We also want to treat the cause if we can. If there's a tumor or a mass that's causing it, if it's steroid use, we want to get them off of the steroids. Whatever we can do to stop the progression. And if you look at this person, I think the changes in them is amazing after they removed whatever tumor was causing the issue that brought on the Cushing's. Nursing interventions, we want to watch fluid. We want to watch their skin. Their skin's very thin. You see all the veins and vessels through it, lots of little spider veins, that kind of thing. They have all the symptoms of diabetes, so we're going to be watching them and their blood sugar levels, and a lot of these patients actually are on insulin. And then we need to do whatever we can to prevent infection for them. Evaluation, again, did everything we do work? And what is their body image disturbance? That is our biggest issue with that. So the final thing we're going to talk about is polycystic ovarian disease. And polycystic ovarian disease is an alteration in the ovaries, and we all know what the ovaries do. The ovaries secrete estrogen and progesterone. primarily, but when you have polycystic ovarian disease, they also produce testosterone, but the testosterone levels are way, way too high. So this patient has irregular periods. They might have male baldness. They might have facial hair. One symptom of polycystic ovarian disease, especially for younger women, is intense hair on their arms and also on the small of their back. Sometimes they will get an excessive amount of hair. These patients are insulin resistant. Sometimes they have diabetes. Sometimes they have hypertension, and almost all of them, unfortunately, have infertility issues. Sometimes they can treat it very, very easily. Sometimes they can restore ovulation with a drug called Clomid. And what really helps a lot is metformin. Because technically they aren't diabetic, but because of the hormone interaction, it causes diabetes. So if they can get the insulin resistance under control, sometimes that helps the fertility. I mean, it's just amazing how all of these hormones interact with each other. These patients tend to be overweight, so you have to make sure that they reduce their weight appropriately. Disturbed body image is a big deal. Ineffective coping, especially when it comes to infertility. If the infertility isn't handled right and the couple doesn't have a good perspective on it, sometimes there is a huge problem in the marriage. So it'd be really unfortunate to have that happen because of something that we can treat and hopefully treat very well. Okay, so here's our final slide on our adventure in endocrine. You know how I always tell you to reduce things to one sentence or just a few words. So here's what I've done with the disease processes we've covered. Diabetes insipidus is low antidiuretic hormone. You'll have intense urination, hypernatremia, that's in the serum. You treat with synthetic antidiuretic hormone. SIADH is syndrome of inappropriate antidiabetic hormone. There's high antidiabetic hormone, low urine output, fluid overload. You treat with sodium and democycline. Hypothyroidism, low T3 and T4, high thyroid stimulating hormone. Everything goes slow. Treat with synthetic levothyroxine. Hyperthyroidism, high levels of T3 and T4 and low thyroid stimulating hormone. Everything goes fast. Treat with removal of the thyroid. Hypoparathyroidism, low calcium in the serum, muscle and cardiac spasm, positive Chopsticks and Trousseau's. There's low phosphate. Treat with calcitrol and calcium gluconate. Hyperparathyroidism, high calcium in the serum. You'll have muscle fatigue, bone demineralization, weakness, heart failure. Treat with fluids, diuretics, phosphate, calcitonin, and Fosamax. Pheochromocytoma, is an increase in catecholamines. You'll see tachycardia, anxiety. Treat with removal of the adrenal glands. Addison's is the opposite. There's an aldosterone and cortisol deficiency. Everything is low. You treat with Florinef and hydrocortisone. Cushing syndrome has an increase in cortisol. Treat with removal of the cause, which is usually a tumor, and treat the symptoms like hyperglycemia. Then finally, polycystic ovarian disease is the increased production of testosterone. Fertility problems ensue, diabetes ensues. Treat with metformin and fertility drugs. So I've reduced everything down to one sentence, but I want you to do, as you study for this unit, is to go back through and put each disease process into the nursing process. What is your assessment? What are you going to see? What is your nursing diagnosis? Use 2 or 3 and make sure one's psychosocial. Let me see. Assessment, diagnosis, plan. What are your goals? What do you want to happen to that patient? How are they going to leave your care? And then how are you going to implement that? And then what's your evaluation? What's their T3 and T4 going to be? Know these labs. What's their calcium going to be if it's normal? And then how are you going to educate the patient? And if you do that for each one of these disease process, you're going to rock this test. So good luck with endocrine, and I hope I didn't bore you to death. Bye now.